ورحمة الله وبركاته. أساتذتي الأعزاء، أخواني أخواتي الأعزاء، أهلا وسهلا بكم أجمعين. ترحب جمعية أطباء الباطنية في ذي قار بكم أجمعين. على الود والمحبة نلتقي، وعلى الخير والعطاء في أمسية جميلة مفعمة بالأمل والدعاء من الله العلي العظيم أن يدفع عنا الوباء والبلاء، وأن يمن علينا بالصحة والعافية، وعلى جميع الأخوة، وخاصة الكوادر الطبية من أطباء وممرضين مقيمين أقدمين وأطباء اختصاص في هذا الظرف الصعب. نرجو من الله العلي العظيم أن يمن على الجميع بالصحة والسلامة. نرحب بالأستاذ الدكتور إحسان الشماع بوجوده في هذا الملتقى العلمي، ونتمنى أن نكون عند حسن ظن الجميع. تقيم جمعية أطباء الباطنية في ذي قار الملتقى العلمي الثاني الإلكتروني بعنوان Highlight on Cardio-renal Syndrome and renovascular Hypertension. يحاضر فيه الأخوة الأعزاء الأستاذ الدكتور عمناف الموسوي من المملكة المتحدة، والأخ العزيز الدكتور أياد حميد تيان اختصاص دقيق في أمراض الكلى في مستشفى الحسين التعليمي. ويشارك معي في إدارة هذا الملتقى الأخ العزيز والغالي الدكتور ضياء خلف العمري استشاري في الطب الباطني. ندعو من الله أن نكون عند حسن ظن الجميع، وأن نحقق الفائدة المرجوة من هذا الملتقى العلمي. يتفضل الأخ العزيز الدكتور ضياء خلف بإدارة الجلسة. تفضل دكتور ضياء.
بسم الله الرحمن الرحيم. الشكر، كل الشكر إلى جمعية أطباء الباطنية في ذي قار، متمثلة برئيسها الأخ الدكتور عباس فاضل، وكل الترحيب بكل الزملاء من كل مكان، وأكيد يتقدمهم أستاذي الفاضل الأستاذ الدكتور إحسان الشماع. أهلا وسهلا بك أستاذنا الفاضل. Dear doctors, it is a very nice time to start our webinar today about nephrology and mainly on renovascular diseases. And let me introduce the first speaker, my colleague, Dr. Ammar Manaf Mahdi, a consultant physician, nephrologist from University Hospital in Birmingham, United Kingdom. Dr. Ammar, ahlan wa sahlan. And you have 25 minutes for your talk about cardio-renal syndrome.
أحسنتم دكتور. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. الأخوة الأخوات الحضور، السلام عليكم ورحمة الله وبركاته. أشكركم على هذه الدعوة الكريمة وإتاحة الفرصة لي بالحديث والنقاش معكم في موضوع من المواضيع الشائكة والمهمة، وربما نوعا ما متروكة أو مهملة لدرجة معينة. Is the screen clear? قاعد تسمعوني زين؟ The screen is clear, everything is okay?
نعم دكتور.
أحسنت. بسم الله. طبعا this subject is quite complex and involve two specialty. One of the biggest specialty, obviously, cardiology, and a complex renal pathology as well. So to integrate the two specialty in one field, it's quite challenging sometimes. One is because of the nature of the disease, and the other thing is actually the specialist nature, because cardiologists tend to be stick to the cath lab, and the nephrologist in a different field, kind of. So that's why I took up this subject and made some interest into when I joined University Hospital Birmingham and set up a service called Cardio-renal clinic to make some collaboration work with a cardiology colleague to look after those complex type of patient. I always like to start with something maybe relevant or irrelevant to the slide I'm going to talk about. But this is, if you take things out of context sometime, it's difficult to understand what's meant to be by the statement. So if someone say to you, exercise is the worst thing in the world and as bad as the invention of gunpowder, now you'd say straight away, this statement is foolish statement. But actually you don't know when it was said, in what context. So we have to look into context of things before we make a judgment and take a decision. And it's always a good decision is based on a knowledge and not a number. So some people stick with number and statistic, but we're dealing with human being. We're not dealing with numbers. Not always the number is right. So we have, again, to take it into context. These are some facts about a cardio-renal syndrome. Heart failure is the most frequent cause, as you know, of hospitalization and actually readmission again, and is one-third of patients reach end-stage renal disease, have some degree of heart failure on the start of the dialysis journey. And renal impairment in heart failure is an independent risk factor of worse outcome. So if you have a heart failure, to add to that, any renal impairment is actually determine the worst outcome. And heart failure and CKD often coexist, and it's double the all-cause mortality in those cohort of patients. And if you divide the cardio-renal syndrome into types to look into the pathology, which one caused which, you're going to go into a dilemma, and it's a lot of pathological process going on there. And as you can see, it's a very busy slide, but it does actually interact a lot, heart and kidney. So you can't segregate the two organs from each other. They work in harmony, irrespective if you like it or you don't. So we have to understand it in depth. In this trial, they looked at the relationship between aggressive diuresis and deterioration of kidney function. Is there any pathology going on at the tubular level to cause the kidney to deteriorate in the context of decompensation of heart failure? So they looked at 141 patients, and they looked at the urine marker called NGAL as a biomarker of tubular injury, which is well known in experimental nephrology, but actually they found no correlation. And as you can see, those people who had AKI or didn't have, there was no significant difference in the urine NGAL to urine creatinine ratio. So there is no direct correlation between aggressive diuresis and acute kidney injury in decompensated heart failure patients. So what is the problem then? Is it the cardiac output issue? Is it because of low cardiac output, it lead to low perfusion of the kidney and hence causing worsening of the kidney function as a result of low perfusion? Or is it something else? In a study, actually, they looked at if they give some medication to improve the cardiac index, actually improvement in cardiac index did not result in improved renal function. So in this study, even though they tried to improve this is very biggest trial, escape trial, they tried to improve the cardiac index, but did not show improvement in renal function. So what is it then? Something going on there. is actually they found that congestion in itself, it does affect significantly the renal function. So the higher the CVP, as you can see from the graph, is the lower eGFR. So as you can see, start from a CVP of 5 to 10 is not start to decrease when you reach 10 millimeter mercury CVP, and is worse as the CVP goes up. So the congestion itself is actually cause glomerular and interstitial pressure, causing the eGFR to drop and the filtration capability of the kidney to decline significantly. So it is very important to keep in mind in treating a patient with congestion, not to be, to worry about the diuretic itself, but worry more about the congestion. What about intra-abdominal pressure? Now, intra-abdominal pressure, very interestingly, that the higher the intra-abdominal pressure, you can even reach a stage where you can stop completely, become the patient or the experimental animal can stop completely passing any urine if you increase the renal venous pressure to 20 millimeter mercury. And that's, the experiment is not recent, is since the 1930s. And as you can see, they tried it on the canine kidneys. So intra-abdominal pressure, very important, especially in case of ascites, of patient heart failure with ascites. And this is how you measure intra-abdominal pressure in intensive care. Now, the mechanism involved in renal congestion, heart failure, again, it's very complex. Too many things. One, decreased cardiac output. It's one factor. Increase intra-abdominal pressure, central venous pressure, as I mentioned. All of these increase the risk of renal congestion ultimately, and the congestion itself causes reduction in eGFR. And the venous congestion itself is an inflammatory, cause an inflammatory response and cause even worse outcome and effect on the heart itself, can increase renal fibrosis, myocardial contractility, reduction, etc. So inflammatory process also get reactivated in those circumstances. But it is still potentially treatable cardiorenal, because if you understand the factor involved in the cardiorenal pathophysiology, then you can address each item separately. Now, volume accumulation, high or low blood pressure, you address, increase renin, aldosterone system activity, increase sympathetic activity. You address all of these factors individually. You have either intervention by medication or correction of those factors or elimination of the risk factor itself help improve the outcome. Now, what did happen before diuretic era? The venous, they used to even do venous section, cause scarification, put them in a hot bath, all sorts of things they tried to make the patient lose some water. That's before the diuretic. So imagine how diuretics is a breakthrough medication came across and relieve a lot of patients who are drowning with water. So, but is it diuretics any good? What trials is there? What evidence we have? Not unfortunately, there's no many trials there to prove how good they are, basically because there is no interest from drug companies. But there are a few there. Some studies showed, three trials showed that it does reduce the mortality, and other trial reduce admission of with worsening heart failure. But interestingly, some other trial showed that it's associated with worse outcome with higher dose of diuretics. And that's actually just a confounding factor, basically because those patients who are demanding or requiring higher dose of diuretics, actually they have worse worse heart and eventually worse heart outcome and mortality. And is there any difference when you use diuretics between bolus or continuous? We can go and disagree on that subject all day, but actually trial didn't show much different. The only difference in those patients, you need to be aware that if you start patient on continuous infusion, you need a bolus at the beginning. So give bolus, and then if you want to carry on with continuous infusion. But actually, if you got someone inpatient and catheterized, you can even use three times a day doses or 4 times a day to sustain diuresis, not necessarily to hook him against an infuser. But the problem and challenge you face always is diuretic resistance. Diuretic resistance is a very important factor, and all physicians scared of, because beyond that, what you're going to do if the patient not responding to diuretics, what is next? What is the next step? And even in the definition, at the level of definition, they haven't reached agreement about how to define diuretic resistant as per se. If you can, as you can see, some people say 160 milligram oral furosemide, others say 80 milligram, others say the amount of sodium you excrete, etc. So there's no yet a consensus about the definition of diuretic resistance. And again, this paper in Circulation of Heart Failure, it did prove that it does associate with detrimental clinical outcome irrespective of congestive signs. So the higher the diuretic you require, and it does, as I mentioned earlier, it does correspond or prove poor outcome in those type of patients. And what causes diuretic resistance? Inadequate dose of diuretics, adherence, low albumin, low blood pressure, etc. All of these factors need to be considered when you are treating a diuretic resistant patient. Now, this is showing you how intravenous diuretics can reach a higher level of concentration in the plasma of patient with heart failure, and whether when you take it orally with food or without food. That's very interesting to know, and so you can time the dosage of diuretics to patient. Let's skip that for the sake of the time. And this is showing you different factors contributing to the diuretic resistant in renal patient. Uremic toxins compete with diuretic agent reaching the proximal tubule, and other factor like acidosis, etc. What is the main drive then? In CKD, actually, reduction of renal mass. If you've got someone who started with CKD and it developed renal failure, they have this low mass, and then filtration will be poor, then responding to diuretics is low. And also competitive with a uremic toxin as well, as I mentioned, and in heart failure, mainly vasoconstriction state and low cardiac output does not allow good renal perfusion. So then the challenges is, as I mentioned earlier, is diuretic resistance and diuretic toxicity, and there's no actually new pill that replacing loop diuretics at this stage. So what should we do? They actually tried veno-venous ultrafiltration, but not many have tried peritoneal dialysis to address the fluid management issue. And this is proven in New England Medical Journal that ultrafiltration using aqua pheresis machine by the bedside of the patient to take ultrafiltration of fluid out of the body actually did not prove of any better outcome. Instead, actually, there was no difference in death or rehospitalization. In addition to that, actually showed more adverse outcome and show more AKI in ultrafiltration group compared to conventional diuretic therapy. So, but why then not PD? Why we didn't use so far PD? People fear of stigmata, being stigmatized that they are on dialysis, and also patient require patient to be involved in the treatment. They are scared to be looking after themselves, and there is a risk of infection, leak, and all sorts of complication they're worried about. But actually, if they are drowning with water and there is no way you can manage their life and improve their life style by only doing this, then I think it's worth trying. And also in UK, we have a problem with funding these type of treatment from the primary sector, or we call the commissioning group. And YPD, it is very gentle, and unlike dialysis, hemodialysis, it's very gentle. It doesn't affect the blood pressure. So if you got low blood pressure with chronic heart failure patient, it's fine. You can do gentle ultrafiltration using osmotic agent like dextrose water. And it's a cure for ascites. If you got someone with heart failure and ascites, you got a tube there. Whenever fluid accumulated, you drain it. And I have very fantastic case. I may have the chance next time to present to you where I transformed the patient quality of life completely by putting a PD catheter and chronically drained the ascites by himself at home, away from hospital full of COVID, and he is enjoying. I just actually had a phone call from, I called him and had a virtual clinic with him earlier on, and he's enjoying his life back to normal. So it is transformative for life for certain patient. I'm not going to go for a PD history, etc. I'm going to skip the slide where you can see that treatment you can do at home at your leisure. This is a picture from the 60s. As you can see, the equipment is very old. Now you don't have to have all of these sitting around your bed anymore, just a small machine next to your bedside. And for the, again, for I don't think I got time for that. There are different type of fluid you could use for this, especially extranil. Extranil is very useful. It's a strong osmotic agent. It doesn't have glucose, doesn't affect diabetic, and it have very strong capability to ultrafiltrate fluid out of your body, and the osmotic gradient is very high. So I've got only 2 minutes, I think. So this is a cohort of patients I collected, 20 patients, and sorry. This is a cohort of patients I published in Kidney Week in 2017.
احنا قاعد يقطع عندنا، انتم عندكم قاعد يقطع؟
أنا قاعد أسمع، أنتم ما قاعد تسمعوني؟
عفوا دكتور، نسمعك واضح، نسمعك واضح.
واضح دكتور، استمع واضح.
نعم. This abstract submitted in Kidney Week in ASN in New Orleans, Los Angeles, and it showed actually I have 20 patients who put on PD, and the outcome of those patients, those who lasted on dialysis for more than 12 months, actually showed a significant reduction on number of admission to hospital as a result of heart failure symptoms. So they are away from a hospital and with better symptom control, and it does prove to be beneficial in those type of patient. That's why Cardio-renal service is important, because you need a heart specialist, heart failure specialist talking to a nephrologist about diuretic resistant, about selecting patient, how to manage them anemia the best. You know that nephrologists very good at managing anemia because of how common it is in their patient, and also how confident they are with managing hyperkalemia, especially when you're using a newer agent like Entresto, which called sacubitril valsartan type of tablet, which can cause hyperkalemia, and also treating metabolic acidosis, which is a major contributory factor in those type of patients, causing them to lack of appetite and lethargic, etc., and affect their daily activity. And also, again, that Cardio-renal service will help you to assess early for PD, so you don't, from a nephrology point of view, You don't counsel them for hemodialysis because those type of patients, they don't do well on hemo. They need to be directed to the appropriate treatment, which is peritoneal dialysis. And finally, to remember, peritoneal dialysis is a feasible option for symptom control in those type of patient, and even can be palliative as well in certain patients because of the heart failure symptoms is unbearable and can reach a stage where the patient is actually begging you for some relief of their symptoms, especially the shortness of breath. But optimization of medical management is a priority of those patients. Hence, a cardio-renal service is a very important aspect. And it is remain a challenging issue and difficult to treat condition. And thank you very much for listening.
شكرا جزيلا. Thank you very much, Dr. Ammar. Very nice presentation. My colleagues, please, for any question, we have 20 minutes at the end of the session for discussion. Before starting to introduce the second speaker, I would like to appreciate and to say أهلا وسهلا دكتور منعم الشوك، الأستاذ دكتور منعم الشوك رئيس المجلس
ضياء انقطعت ورجعت الشبكة يمن.
يلا إن شاء الله.
عفوا دكتور ضياء تسمعنا.
Sorry, this is Nadi, Internet Services. Everyone hear me?
نعم دكتور نسمعك.
The second speaker is Dr. Ayad Hamid Tailan, consultant physician, specialist in medicine and nephrology with renal transplantation, and he will talk his lecture about renovascular syndrome, renovascular hypertension. Dr. Ayad, you can start your talk.
بسم الله الرحمن الرحيم. شكرا جزيلا استاذنا الكريم دكتور ضياء، واهلا وسهلا بكل الاساتذه الكرام والاخوه الاعزاء. صوت واضح؟
نعم.
واضح دكتور واضح.
I will talk about renovascular hypertension, and by definition it is a syndrome of elevated blood pressure which is produced by a condition that interferes with arterial circulation of the kidney. So a reduction or loss of renal, arterial or venous blood flow will be associated with one or more of distinct clinical syndromes. One of them is renovascular hypertension. There are others like ischemic renal disease, unstable cardiac syndromes, renal infarction, atherosclerotic renal disease, and renal vein thrombosis. And because of widespread application of renin-angiotensin aldosterone system blockers in management of different conditions like hypertension, congestive heart failure, and other proteinuric diseases, so this has increased the exposure of individuals with undetected renovascular hypertension to these agents. So therefore, there are many cases of renovascular hypertension will go undiagnosed unless hypertension will become more difficult to control or a kidney dysfunction develops. In order for renal blood flow and renal perfusion pressure to be affected by renovascular stenosis. And in order to activate the renin-angiotensin aldosterone system, there should be a narrowing of at least 60 to 80% of the cross-sectional diameter area of the renal artery in order to produce that effect. And what is the mechanism behind hypertension when renal artery stenosis occurs? And this will depend on whether we have one artery stenosis or whether we have the total kidney mass affected by stenosis. When we have one artery stenosis, they call it two kidney hypertension. On the affected kidney, there will be reduced renal perfusion, and this will lead to activation of the renin-angiotensin aldosterone system. So this leads to angiotensin 2 dependent hypertension because the effect of vasoconstrictive effect of angiotensin 2. While on the non-affected kidney, which has normal renal perfusion, there will be increased renal perfusion, and this will lead on to increased sodium excretion. So this will lead to pressure natriuresis, and this will prevent volume overload from occurrence. So in two kidney hypertension, the plasma renin activity will be elevated, and there will be a lateralization feature. The other mechanisms when we had bilateral renal artery stenosis, or when you had a solitary kidney, single kidney with a stenotic artery, they call it one kidney hypertension. And when the renal perfusion reduced, there also will be activation of the renin-angiotensin aldosterone system. While on the other hand, there will be impairment of sodium and water excretion, leading to volume expansion. And this volume expansion will inhibit the renin-angiotensin aldosterone system. So here, plasma renin activity will be normal or low, and there will be absence of lateralization features. Clinical features of renovascular hypertension, it may be superimposed with primary hypertension, so the clinical differentiation may be difficult. Some patients may be presented with accelerated hypertension, with resistant hypertension, or with hypertension urgency or emergency. There will be a higher nocturnal pressure, thus to say the patient will lose their normal nocturnal dipping. There will be more severe target organ manifestations like left ventricular hypertrophy, albuminuria, than a patient with essential hypertension. Also, there will be hypokalemia and metabolic alkalosis, and that's because of secondary aldosteronism, and rarely may be associated with renin-mediated hemodynamically induced nephrotic rangeproteinuria, which may regress with the treatment. Also, there will be a syndrome of polydipsia associated with hyponatremia, and this is because of the action of angiotensin 2. Who should be screened for renovascular hypertension? Any patient with abrupt onset of hypertension at relatively young age, below 30 years or above 50 years, at relatively elder age. A patient with worsening control of a previously well-treated hypertension. A patient who had recurrent episodes of a flash pulmonary edema. When there is occurrence of acute kidney injury precipitated by initiation of ACE inhibitors or angiotensin receptor blockers. Any patient with unexplained kidney failure, when there is a unilateral atrophic kidney, unexplained hypokalemia, and the presence of atherosclerotic disease in other vascular beds. The two most common causes of renovascular hypertension are renal artery fibromuscular dysplasia and atherosclerotic disease. And there are many other causes depending on whether they affect a single artery or both arteries of the kidney. Among them are renal artery aneurysm, many vasculitic lesions, coarctation of aorta, and many other conditions. Fibromuscular dysplasia is an inflammatory non-atherosclerotic arteriopathy and characterized by arterial medial smooth muscle cell proliferation and fibrosis. It is the most common cause of renovascular hypertension in children and young adults, and the vascular distribution of fibromuscular dysplasia involves primarily the renal and cerebral arteries. There will be bilateral renal artery involvement in 25 to 35% of cases, and cerebrovascular involvement in up to 65% of cases. And there are other sites like coronary, mesenteric, celiac, splenic, aortic, and peripheral vasculature also may be involved. About 90% of fibromuscular dysplasia cases occur in women, and the mean age of onset of hypertension is 43 years. A familial fibromuscular dysplasia also occurs in 10% with autosomal dominant inheritance pattern, And the most common histological variant of fibromuscular dysplasia is medial fibroplasia, which occur in 85 to 100% of cases. And here will be alternating thin and thick ridges of collagen and elastic tissue deposit, resulting in discrete stenosis alternating with aneurysmal sections characterized by fragmented internal elastic lamina, and this will produce the characteristic string of beads appearance on angiography. There are other rare histological types of fibromuscular dysplasia. As we said, the medial fibroplasia is the most common. Perimedial fibroplasia, medial hyperplasia, intimal and adventitial, and these are very rare. Fibromuscular dysplasia generally involve the segment of renal artery beyond the first 2 centimeters from the ostium, and it may coexist with atherosclerotic renovascular disease. The most common clinical presentation is early onset hypertension in young to middle-aged women, and also cerebrovascular lesions may be manifested with headache, with pulsatile tinnitus. Also, there may be bruit over carotid arteries, over the gastrium or femoral regions, and it should be considered in any younger patient presenting with hypertension and stroke, or transient ischemic attack, or subarachnoid hemorrhage, or amaurosis focal. The natural history of fibromuscular dysplasia has not been adequately studied, although the disease progression may be manifested with a new focal lesion within the same arterial bed, or worsening the same luminal arterial luminal narrowing within the same lesion, or involvement of a new vascular territory, or maybe complicated by arteriovenous fistula or aneurysm. There are many disorders associated with fibromuscular dysplasia, as we say, collagen vascular disease, alpha-1 antitrypsin deficiency, cigarette smoking, homocystinuria, Crohn's disease, and many other conditions. Atherosclerotic renal artery stenosis, and this is the most common cause of renovascular hypertension in patients over the age of 50. The prevalence depends on population screens and range from 4% to 60%. And it is a contributor to development of end-stage renal disease in up to 22%. And among patients with chronic congestive heart failure, renal artery stenosis has been reported in up to 50% of cases. And generally, it occurs in patients with more generalized atherosclerosis involving the aorta, the peripheral vasculature, and coronary arteries, and can be bilateral in about 20 to 40% of patients. What are the predictors of atherosclerotic renal artery stenosis? These include a history of hypertension, presence of chronic kidney disease, coexisting peripheral vascular or coronary artery disease, presence of abdominal bruit, and history of smoking. The natural history of atherosclerotic renovascular disease typically progress over 2 to 5 years, and the progression usually defined as greater than 25% luminal diameter narrowing or severe stenosis progressing to vascular occlusion. A measurable loss of kidney length more than 1 centimeter is less common, and changes in serum creatinine are often minimal. And progression is most likely in patients with more than 60% stenosis and often occur without changes in blood pressure control. And it appears that therapy with statin may reduce this progression, and also it may induce regression of atherosclerotic renal artery stenosis. Middle aortic syndrome, this is a rare entity, which is when there is a segmental or diffuse narrowing of the abdominal or distal descending aorta and causing renovascular hypertension, which is usually noted in infancy. Maybe concomitant proximal renal artery stenosis occurring up to 80%. And as we said, it's congenital, but may be associated with fibromuscular dysplasia, with neurofibromatosis, and other congenital anomalies. And it can cause complicated by claudication of lower extremities as well as mesenteric ischemia. Ischemic renal disease, this describes both the hemodynamic and structural consequences of reduced renal artery perfusion on kidney. And a common clinical scenario in patients with atherosclerotic renal artery stenosis is the presence of both hypertension and kidney dysfunction. And in clinical practice, it remains difficult to distinguish CKD secondary to hypertensive nephrosclerosis from a reduced kidney function resulting from atherosclerotic renal artery stenosis. What are the clinical presentation of ischemic renal disease associated with atherosclerotic renal artery stenosis? Acute kidney injury with control of blood pressure, when using AC inhibitors or angiotensin receptor blockers, acute kidney injury with aggressive diuresis in patient with congestive heart failure, chronic kidney disease otherwise unexplained in atherosclerotic age range, chronic kidney disease with asymmetric renal size, acute or chronic kidney disease and renovascular hypertension, acute or chronic kidney injury with episodes of a flash pulmonary edema, unexplained rapid decline in GFR and CKD, and oligoanuric kidney failure not otherwise explained in patients with atherosclerosis and hypertension. Diagnosis of renovascular hypertension, the gold standard for diagnosis is renal arteriography, although it carries the risk of contrast exposure. There are others like renal artery duplex ultrasound, CT angiography, and MR angiography. Renal artery duplex scanning has the advantage of being inexpensive and require no contrast. It is most effective in detecting lesions of the main renal artery near the ostium, making it a better screening test for atherosclerotic renal vascular disease than for fibromuscular dysplasia. But it has disadvantage being operator dependent, and it will provide little functional information regarding the kidney beyond the vascular lesion. Magnetic resonance angiography with gadolinium contrast, this gives excellent imaging of the main renal arteries, but has also limitations, which are the recognized tendency to overestimate luminal narrowing and limited sensitivity for middle and distal vascular lesions. It is less sensitive than CT angiography for diagnosis of fibromuscular dysplasia. CT angiography is highly sensitive for identifying lesions associated with fibromuscular dysplasia and is a good screening test for these patients who generally have a good kidney function. But there are few tests can accurately predict the favorable response to intervention. We have two of them. They are captopril renography and measurement of renal vein renin levels. Captopril renography, this will provide a view of the rate of isotope appearance and washout, reflecting the sequence of renal blood flow and filtration. And to provide the functional information regarding the excretory capacity of the kidney, as well as emphasizing the role of angiotensin II in maintaining the GFR. It has a high negative predictive value when completely normal, but many intrinsic renal abnormalities unrelated to the main renal artery may change this curve, and which limits its value in the presence of reduced GFR. Renal vein renin measurement, lateralization of renal vein levels more than 1.5 to 1 of stenotic to non-stenotic kidney ratio to predict a favorable blood pressure response for more than 90% of patients. Because failure to lateralize also carry a favorable response in almost half of patients, so the negative predictive value is limited for this test. Resistive index, this can be done by duplex ultrasound by measuring the peak systolic and the lowest diastolic velocity. It improves the ability to predict the outcome after revascularization. And in general, a higher resistive index is associated with a greater degree of intrinsic renal damage and therefore a diminished predicted benefit from revascularization. Treatment of atherosclerotic renal artery stenosis and fibromuscular dysplasia. The treatment of choice for fibromuscular dysplasia is percutaneous renal artery angioplasty, usually without stenting, and complete cure, which is defined as normalization of blood pressure without the need for medication. This occurs in 35 to 45% of cases, and in over 85% of cases of fibromuscular dysplasia treated with percutaneous angiography, the blood pressure is improved with reduction of number of antihypertensive medication. Inadequate initial treatment or restenosis also has been reported in up to 35% of treated cases. But the optimal treatment of atherosclerotic renal artery stenosis presenting with renovascular hypertension or other clinical syndromes, this has been the subject of much controversy. And the medical management is based on blood pressure control with appropriate antihypertensive medication, along with lifestyle modifications and other medical intervention, aiming at reducing the cardiovascular risk associated with atherosclerotic renal artery stenosis. These include aspirin, the use of aspirin, statin, smoking cessation, good glycemic control in patients with diabetes. There are 3 large randomized control trials. These trials compare the use of medical therapy alone versus medical therapy and stenting for renal artery atherosclerotic renal artery stenosis in patients with CKD. And the end point for these studies was on the rate of progression of CKD and the overall cardiovascular and renal event and overall mortality. And this trial failed to demonstrate a benefit from revascularization toward the kidney outcomes, toward cardiovascular outcomes and mortality compared with medical management alone. And in Astral and Coral trial, they show no difference in blood pressure control between the revascularization group and the medical management group. And also there were a very procedural complication, was 9% in Astral and 5% in Coral trial. So based on this data, the current consensus opinion is that the initial treatment of patients with renovascular hypertension and chronic kidney disease associated with atherosclerotic renal artery stenosis should be focused on medical management approach. But there are certain clinical indications to consider renal artery revascularization for patients with worsening kidney function due to ischemic renal disease, uncontrolled hypertension, failing medical therapy, for patients intolerance to medical therapy, for those who have recurrent hospitalization for pulmonary edema, for those who have progressive renal atrophy, and for potentially reversible dialysis dependency due to ischemic renal disease. Who are likely to benefit from revascularization? Those who have recent onset or accelerated hypertension, and those who have recent onset or progressive renal failure, and those with bilateral or stenosis in a single functioning kidney, a patient with recurrent flash pulmonary edema, and those who have a resistive index less than 0.8. And patient not likely to benefit from revascularization when he has pre-existing long-standing hypertension, and when he has a small kidney size less than 8 centimeters, and when the resistive index more than 0.8, and when physiological there is a insignificant stenosis on capsulorenograph, and a patient with advanced age. And thank you very much.
Thank you very much, Dr. Ayad. Very interesting and perfect timing of your lecture. Thank you again. Let me start asking our colleagues about Cardio-renal. Start with Dr. Ammar. A question from Dr. Tahsin Al-Kinani. How strong the evidence of peritoneal dialysis in cardio-renal syndrome? Dr. Ammar.
There is no randomized control trial yet. There was one randomized control trial, RCT, tried to recruit in the UK but failed. So that's why cardio-renal service need to be in place to make those trials happening. So there's no strong evidence, but you can look at, there is a many retrospective cohort studies showed some benefit. But the best way, as you know, the best and the strongest evidence is to do RCT. And there is no RCT as of yet. Next question.
Thank you, Dr. Dr. Ammar, another question. Dr. Ahmad Tahir. He is asking you whether are you agree that using statin with ACE inhibitor is beneficial in those with cardio-renal syndrome?
So obviously, ACE inhibitors, patient with heart failure, they have to be on some sort of ACE inhibitors or ARBs, some angiotensin receptor blocker. But in certain circumstances, you have to hold it off, but you have to put in place a timing to restart it because it's very essential for the heart. Now, we know that in certain cases when the patient is septic or they got infection, diarrhea, or whatever, you hold off ACE inhibitors because of the kidney. But you have, even if you do that, you have to be careful and put a plan in place to restart the agent once the kidney function stabilizes. Now, with acute kidney injury, obviously you stop it, but you put in a plan in place to restart again. Now, using statin is beneficial as in generally with people with ischemic heart disease as a cause of the heart failure, because it has anti-inflammatory as well as anti-lipid functionality. So it is beneficial, but only those who for secondary prevention rather than primary prevention. Hopefully that answered the question.
Thank you. Another question from Dr. Muayyad. He is asking, what about acute kidney injury due to hypovolemia because of blood loss in patients with heart attack?
So blood loss, I mean, they're bleeding and they have heart failure. And so my understanding from the question is patients who bleed for any reason, like let's say upper GI bleed, and they got bad heart, obviously its priority is, if they are becoming anemic, it can worsen the heart failure symptoms, then you have to transfuse them with diuretic cover probably, because you're going to volume overload the patient. So you always have to be careful about the volume. But if they are hypovolemic, as the question says, then no worry about other things, except actually in fact you need to keep in mind the potassium. If the patient has advanced kidney problem, and then you need to be careful about massive transfusion, because it will load them with potassium. In which case, these days, you can use some a potassium binder as a localma called sodium zirconium, or patiromer, both of which lower the potassium. So you got now a way of getting away without needing dialysis in those type of patients.
Sorry, there is another question for you again. How frequent should monitor renal function test in heart failure, taking diuretic in acute and chronic patients?
So frequency, it's based on the clinical judgment of how the kidney function is stable. So certain patient who had a cardio-renal syndrome, you worried about, their fluid status. You check the UNEs, the renal function, every time you change the dose of diuretics or the ACE inhibitors. So if you increase the ACE inhibitors dose, or you increase the diuretics, you check within a week time, you check the renal function. But generally speaking, if you don't do any change, every 3 months or 6 months, depending how stable is the patient, you do a routine kidney function test.
Thank you, Dr. Ammar. Dr. Abbas will complete the list of
Thank you very much for all lectures and for attendance. Question from Dr. Abdelamir Abdelbari. He's a well-known cardiologist in the Basra city. He thank you for informative lectures, he said. And there is Dr. Ammar, is there any specific therapy improve mortality in cardio-renal syndrome? Thank you very much.
No problem. To improve mortality, the problem with patients with cardio-renal, we worried about their symptoms more than anything, quality of life. To improve quality, I mean, the most of the study obviously come from the heart, they look after the contractility, improve the symptoms. As we said, if you got a renal impairment alongside with heart failure, the mortality is higher, the outcome is worse. to reduce that, you need to address each entity separately. So for example, you need to use a proper beta blocker, you need to use AC inhibitors, you need to use diuretics to the extent that you make them euvolumic. That way, obviously, overall improve cardiac outcome. And spironolactone, by the way, there was one question about aldactone, spironolactone. It is beneficial in those circumstances because they are hyperreninemic state, and the potassium sparing diuretics, it does play a good role and improve the New York Heart Failure Association grade of their dyspnea. So it is quite important to address those. Overall, there are new agents that proven to improve the outcome and mortality. There is a new drug called Entresto, sacubitril valsartan combination tablet, that actually it does improve the outcome in patients. But the problem with advanced kidney disease in those type of patients, you can't use it, not licensed yet, but there are trials going on to address that as well. And we're hoping that we'll be able to use it. In selective cases, I have used it in dialysis patients, this type of agent, a new Entresto, in advanced heart failure.
Thank you very much, Dr. Ammar. A question from Dr. Mudar to Dr. Ali Mohsen. Is there superiority of bisoprolol over carvedilol and metoprolol in all-cause hospital mortality and all hospitalization of heart failure? Is there any evidence base for the superiority?
حقيقة in heart failure, according to the American guidelines, only 3 beta blockers are approved, which are bisoprolol, metoprolol succinate, not tartarate, and carvedilol. Each one was approved based on a large outcome clinical trial. For bisoprolol, it was the CIBIS-2 study. For metoprolol succinate, it was MERIT-HF trial, and for carvedilol, it was Copernicus. كلها صارت سنة 99 2000 2001 هاي الحوالي. The risk reduction أو relative risk reduction بالمورتاليتي والhospitalization كانت متساوية للثلاثة. 34% للبيسوبرولول، للميتوبرولول ساكسينيت، وكذلك للكارفيديلول. فإذا نريد نجاوب من ناحية evidence based medicine, they are the same, to be honest. يبقى شنو؟ يبقى مثلا المرضى أو the patients are not similar to each other. فممكن features مثلا موجودة بالبيسوبرولول تكون مناسبة ل some patients، وممكن features other patients تكون ما يناسبهم. for example carvedilol. for example إذا نحكي مثلا على patients with bronchospastic disease، هنا راح نمشي أكثر مع المور كارديو سيلكتيف واللي هن بيسوبرولول، ميتوبرولول، ساكسينيت rather than carvedilol على اعتبار بالفا and beta effects. فجوابا على سؤال دكتور مظهر، clinical trials and outcome clinical trials, the risk reduction بالمورتاليتي والhospitalization is the same بالنسبة للبيسوبرولول، ميتوبرولول، ساكسينيت and carvedilol. إذا نقدر نريد ندور individual superiority للبيسوبرولول.
شكرا جزيلا دكتور.
شكرا دكتور. بس ممكن الهارت ريت ريدكشن يكون more with bisoprolol compared with other beta blockers like metoprolol or carvedilol. شكرا.
شكرا جزيلا دكتور علي. دكتور اياد, question from دكتور مؤيد عزيز. طبعا احنا نرحب بدكتور مؤيد عزيز موجود معنا بالملتقى العلمي. دكتور مؤيد يسأل renal angioplasty or renal catheterization in Iraq, it is available, and is there any number of, يعني إذا عندك أي شيء عنه. دكتور اياد.
معي دكتور عباس عني؟
renal angioplasty or renal catheterization, it is available in Iraq, And is there a number?
Yes, I'm not informed by this. I'm not informed by this information. I don't know.
Yes. Thank you very much. Thank you very much. تفضل دكتور ضياء كمل الكويشن.
شكرا دكتور عباس. Question from Dr. Imad. Another question, Dr. Ammar. Is it common to see patients with cardio-renal syndrome due to diastolic cardiac dysfunction?
So yes, we do see them, but not as common as with the reduced ejection fraction. And most trial actually is with reduced ejection fraction. Most of the trial conducted is with reduced ejection fraction. I think the reason behind that is actually to select the patient, and there is subjective categorization of those patients by ejection fraction. But in diastolic dysfunction, it is difficult to monitor those type of patients and get to the outcome. So most of the trial conducted so far in with heart failure with reduced ejection fraction. But yes, equally we see diastolic dysfunction patient with impaired kidney function, especially severe degree of diastolic dysfunction.
Thank you very much. Question from Dr. Thi Qar. Does the angiotensin converter enzyme inhibitor or ARA
الو ما قاعد تسمعوني؟
عفوا دكتور الظاهر
بس
خالد
دكتور
يمدح.
ضياء ما نسمع.
دكتور ضياء صوت راح. اي بلي السؤال كان
another question, Dr. From Dr. الوائلي يسأل, does the angiotensin converting enzyme inhibitor or ARAB are contraindicated or used cautious with patients with single kidney?
There's no contraindication to use ACE or ARB in single kidney patient. The only contraindication you get is unilateral renal artery stenosis, as Dr. Ayad was mentioning, bilateral renal artery stenosis. But again, you can still use it if you need it, but with very cautious and monitor renal function. That's all you need to do. So it's not an absolute contraindication, and in single kidney that's fine. You still use it. Actually, it has protective effect, especially with patients who have the protein in the urine, as well as if they have heart failure. So yes, you still can use it with a single kidney.
Dr. Tahir Zaidi asking about what can be used spironolactone in heart failure on patients with renal failure.
Depend on the degree of renal failure. So if you've got a patient who is stage 5 kidney disease, who have eGFR below 15, and you are worried about the potassium, then the potassium sparing diuretic is it might be very tricky to use. But I've used it with patients who eGFR of 20. Just monitor potassium, make sure that they are okay with potassium. If they have a low potassium, because most of patients on high diuretics, they tend to have low potassium, and so I can use it for the benefit of the heart. So I do start spironolactone for my cardio-renal patient who come to my clinic on a Friday afternoon.
Thank you, Dr. Ammar. Dr. Ayad, if you are present. Dr. Ayad.
نعم موجود دكتور.
سؤال من الأستاذ الدكتور منعم الشوك. He is asking about bilateral renal artery stenosis and their management.
Well, this depends initially on renal captoperitoneal angiography and to see whether they can benefit from revascularization or not. But in general, there is so much debate about the management of atherosclerotic renal artery stenosis. And the general consensus is toward medical management. And the revascularization is limited to certain indication for those, for example, presented with recurrent flash pulmonary edema, those with difficult to control hypertension. So if the patient with stable kidney function and good control blood pressure on medical management, the advice toward medical management. If he otherwise develop progressive worsening of kidney function or intolerance to medical therapy, or he has resistant hypertension to medical therapy, we may go toward revascularization in these patients. Okay.
Thank you. Dr. Ali, you have a question from Dr. Amr Diab. He's asking about the role of bisoprolol in aortic dissection.
نعم. حقيقة بيتا هنا البيسوبرولول لايك اذر بيتا بلوكرز، يعني هو من الميديكيشنز اللي تعطى under specific indications اللي هن بالنسبة لنا hypertension, heart failure and chronic stable angina. يعني compliance wise احنا كcompany we cannot promote the use of bisoprolol outside those indications، يعني هذه هي فقط اللي approved indications اللي عندنا. Other than this هنا it doesn't differ أو compare to other beta blockers، يعني هم راح ينطينا الإفكت اللي تنطيه بقية البيتا بلوكر. So يعني هذا الاستخدام specifically for the aortic dissection إذا apart from heart failure أو hypertension أو chronic stable angina we cannot promote this use.
شكرا دكتور علي. Another question from دكتور عماد حاتم.
نعم.
He is asking if there is any comparative study between bisoprolol and metoprolol.
هنا when I prepared my presentation I searched actually the literature for head-to-head comparison between bisoprolol and other beta blockers. Unfortunately, I couldn't find a single study comparing bisoprolol to nebivolol regarding the use in hypertension head-to-head. يعني اكو ترايلز بتقارن البيسوبرولول مع البلاسيبو وكذلك النبيفولول مع البلاسيبو، بس head-to-head bisoprolol and nebivolol صراحة ما لقيت هيك trials. However, both are indicated for the treatment of hypertension حسب الامريكان guidelines of hypertension. ما بالنسبة للجايدلاينز حقيقة ما تفضل specific beta blocker over the other بالtreatment of hypertension alone. أما إذا كان in combination with other comorbidities فأكيد الهارت فيلر إلى الانديكيتد أو الابروفد بيتا بلوكرز كذلك الاسكيميك هارت ديزيز وغيرها. جدير بالذكر هنا أنه البيسوبرولول is indicated for hypertension, heart failure and chronic stable angina, while nebivolol is indicated for hypertension, but according to the American guidelines it is not indicated for heart failure. بينما European guidelines give approval for nebivolol in heart failure, it is not also indicated in chronic stable angina unlike bisoprolol. أتمنى هذا يكون يعني جواب كافي للدكتور.
Thank you دكتور. دكتور عمار إذا موجود. دكتور عمار if you are present. There is a question from Prof. Mun'im al-Shawk. He is asking about the hepatorenal syndrome, and he said that we noticed a poor response to diuretic than in cardio-renal syndrome.
There is no good response. Is that the question? What is the question? I can't see it. Can you say the question again?
Question he writes that question to Dr. Ammar about hepatorenal syndrome.
Okay,
we noticed a poor response to diuretic than in cardio-renal syndrome.
Basically, in hepatorenal,
and he needs explanation for this. No.
Yes, the main problem in hepatorenal you could see, especially in chronic liver disease patient, you see very low albumin. because they lose a lot of protein in the ascites fluid, etc., and the low protein synthesis by the liver, and it is one of the diuretic resistant causes is low albumin, because a diuretic is protein bound. To reach the kidney, they need albumin to reach the kidney. So sometime we have to give albumin alongside with IV furosemide to induce diarrhea in those circumstances. And it does work sometimes. We use it in nephrotic syndrome, for example, with low albumin, severe low albumin. They're not responding to diuretics, and we give them some albumin along just to try to force diurese them. And it is very diuretic resistant, the hepatorenal syndrome, and generally speaking is worse even outcome in hepatorenal than cardiorenal, because they don't do well neither on dialysis or anything. Unless you give them a fresh liver, they will not survive hepatorenal.
Thank you, Dr. Ammar. Dr. Ammar, another question from Dr. Tahsin Al-Kinani. Or he is another question or comment.
No.
He wrote that, but if cardio-renal syndrome is caused by renal congestion rather than reduced cardiac output, then the incidence of cardio-renal syndrome should be equal or even more with heart failure.
So correct. Is obviously congestion is higher in heart failure with preserved ejection fraction, especially if they have right-sided heart failure. And actually, the prognosis in this type of patient is worse even than the reduced ejection fraction patient, because the right side and the low blood pressure and severe congestion, and that's why when you come to a point where they are resistant to diuretics, we use the PD to manage that congestion and get a proper ultrafiltration, and especially if they develop ascites. So yes, that it can be, but there is no comparative how common which. We're seeing increasingly heart failure with preserved ejection fraction, but this diagnosis is not historical as the reduced ejection fraction one. So it the attention become more and more recently, and that's why you may see more study about HFpEF, as they call it in the short term.
Thank you very much, Dr. Ammar. And the last question or a comment from Dr. Abbas. Dr. Abbas, start.
شكرا جزيلا دكتور ضياء. I have commented Dr. Ali Mahsin about the beta blocker in hypertension. Most of the guidelines not put a beta blocker as the first line treatment of hypertension, except if there is any compelling indication like heart failure, chronic coronary artery disease, and others. But I reading in the last 1 month Canadian guideline hypertension 2020 put beta blocker as a first line drug therapy in the treatment of hypertension in gent age less than 60. Does you have any other idea about this jumping in putting the beta blocker in the first line treatment of hypertension? Thank you very much.
نعم مثل ما تفضل الدكتور most of the guidelines ما خلت البيتا blockers first line when treating hypertension alone without comorbidities. حقيقة بعض الجايدلاينز وانا هذه سامعها كذلك من بعض اطبائنا يعني السب سبيشالتي كارديولوجي بالعراق يقولون احنا عادة ننطي البيتا بلوكر even from the start in case اذا شفنا المريض مثلا young with high sympathetic drive يعني it is up to their clinical assessment. اما اذا نحكي most of the international guidelines فاغلبها تتفق على أنه البيتا blockers are preferred when hypertension is associated with, for example, heart failure, ischemic heart disease, post-MI, etc. من comorbidities. I don't have a specific explanation for what you mentioned about the Canadian guidelines. And actually during those minutes I have checked for السؤال اللي تفضل به دكتور عامر على aortic dissection. According to the American guidelines, beta blockers in general are the preferred antihypertensive agents for patients with thoracic aortic dissection. وهنا البيسوبرولول يعني حال مثل ما قلت any other beta blocker in this regard. There is no specific preference to bisoprolol from other beta blockers in this regard.
دكتور علي إذا ممكن هاي النقطة the labetalol in dissection it might be beneficial اللي عنده alpha effect as well as beta. Labetalol generally I've seen patients who got dissection that they put them on a high dose and they aim for blood pressure lower than 120. So yes, but beta blocker generally, and I have to say as well, you need to add to your slide to next speaking. Actually, in dialysis patients, bisoprolol reduce the mortality. So every hemodialysis patient, which is not all nephrologists do that. They ignore the fact that they need some beta blocker, irrespective if they have heart failure or not. The reason behind that is patient on dialysis, they get what we call cardiac stunt. Cardiac stunt is like a shock. Every time they go on dialysis, there is a stunt to their heart. With beta blocker, it does help to relieve that stunt, and the outcome and mortality is much better in patient with beta blocker. So I suggest to put that in one of the indications.
Thank you very much, Dr. Sarah. This is a new information for me, and I will consider it in my next presentations. Thanks a lot.
You're welcome. Thanks. Aku question from Dr. Jawad Al-Musawi.
شكرا جزيلا. Thank you very much.
Dr. Diya.
Dr.
Jawad Al-Musawi. Dr. Jawad Al-Musawi, he put a question. I think we didn't answer it. إذا عندكم time, I can answer it. He asked that there is no good outcome for the use of diuretics, and you not remember which type of diuretics. I didn't say there is no good outcome for diuretics. I said the higher the dose of diuretics, it's associated with worse outcome. But the diuretics is essential part of management of heart failure and cardiorenal syndrome. And it is the first choice. That whether it's furosemide or not, this is another question. By the way, torsemide, which is available in the United States, and available in both form, IV and oral, better because it has a longer half-life, but it is not available even in the UK. I'm surprised why is that. And the other thing is bumetanide as an oral agent is superior than furosemide because it has better bioavailability. So as a preference agent for diuretics, you could use oral agent. So I always put patient on IV furosemide first. Then when I want to switch to oral, I put them on oral bumetanide. And the dose is obviously 1 milligram equal 40 milligram of furosemide. So that's I do. And the conversion factor is plus 40. So if the patient on 80 furosemide, I convert him to 2 milligram of bumetanide plus 1 milligram. And that's equal to IV because IV is more potent and more efficient. So to sustain the diuresis. So there is an art of using diuretics. We shouldn't go simply by BNF or whatever drug handbook that you use. But there is an art of you read about diuretics, you're going to manage it as you use it with this, as good as steroid when you are a rheumatologist.
Thank you, Dr. Ammar. Thank you, my colleagues. Thank you for our lecturers today, Dr. Ammar, Dr. Ali, for this nice presentation. And great thanks for my teacher, Dr. Hassan.
الصوت انقطع من
Great thanks for my teacher, دكتور إحسان الشماع. Thanks for staff دكتور منعم الشوط. Thanks for Dr. Serkis to attending our webinar today. And دكتور عباس رئيس جمعية أطباء الباطنية will close this webinar. دكتور عباس تفضل.
شكرا جزيلا دكتور ضياء. طبعا أتقدم بالشكر والجزيل للأخوة الأعزاء المحاضرين، طبعا الأخ العزيز المبدع دكتور عمار مناف الموسوي استشاري أمراض الكلى في المملكة المتحدة، وأيضا الأخ العزيز الغالي دكتور آيات حميد كيلان اختصاص دقيق في أمراض الكلى مستشفى الحسين التعليمي، والأخ الغالي والعزيز دكتور علي محسن من شركة سينو سبيكر. طبعا والشكر والتقدير يا أخي الغالي والعزيز إدارة الجلسة المبدع دائما دكتور ضياء خلف العمري. طبعا والشكر والتقدير والعرفان لجميع الأخوة الحاضرين من أساتذتي الذين أعتز بأن كنت طالبا عندهم، الأستاذ الدكتور إحسان الشماع، الأستاذ الدكتور منعم مكشوك، الأستاذ الدكتور سركيس، كل الأساتذة مع كل الاحترام والتقدير للأخوة الأعزاء الحاضرين في هذا الملتقى العلمي الرائع، أتقدم لهم بالشكر الجزيل. وإن شاء الله الفعاليات العلمية القادمة ممتعة وأكثر. بالأخير أتقدم بالشكر والتقدير للجهود الرائعة اللي بذلتها شركة أسينو، وبالأخص الأخ الغالي دكتور ليث جبار ومعه الأخوة الأعزاء في شركة أسينو. وإن شاء الله الأمن والأمان والاستقرار في بلدنا العزيز العراق، والصحة والعافية والسلامة للجميع. اللهم احفظ الجميع في هذا اليوم وفي كل يوم بحق محمد وآل محمد. شكرا جزيلا لكم إخواني الأعزاء. شكرا، نلتقي على ملتقيات علمية قادمة. مع السلامة.
شكرا جزيلا على الفرصة هذه دكتور عباس رحمه الله. شكرا جزيلا جميعا لكم جميعا إن شاء الله. ممنون منكم.
شكرا جزيلا
للجميع.
شكرا دكتورات. شكرا علي. شكرا للجميع إن شاء الله. مع السلامة
دكتور. الله يسلمك. مع السلامة.
شكرا جزيلا. شكرا.